So good evening, everyone, and welcome back to Tuesdays with Teachers. This is season 2, episode 2, and I'm so excited we are doing this again. But now as a fortnightly series, 2 sessions every month. And for this month, we started with something that everyone wanted to understand better, that's color Doppler in obstetrics. And we had a brilliant session on 2nd of September, and we are back today for the beyond of color Doppler. Let me say this, that these two sessions have been indeed special because we have two exceptional teachers here, the kind of teachers who make complex topics look so simple and fun. It really doesn't get better than this. I want to take a moment to acknowledge the brain and heart behind this entire series, Dr. Mitra Saxena, one who blends intellect, passion, and purpose in everything that she does. Apart from having held many positions, she was recently elected as the VP of Foxy with a thumping majority. She's the reason we have such thoughtfully curated academic programs, and she brings in teachers who are not only the best in their fields, but also know how to teach without the usual frills and fuss. So now with great pride and warmth, I invite Dr. Mitradi to welcome our delegates and introduce our speakers for the evening. Over to you, Mitradi.
Thank you, Vaidehi. Thanks a lot. And actually, basically speaking, I think it is the 123 strong Foxians who take out their time, and I'm sure by the end of the day, we'll have many, many more join in. And because we are all having one passion in common, and that is we all want to understand, we want to decompose a tough topic. Frankly speaking, our patients are very educated, they are willing to spend money, but how sensibly we can advise the necessary test, interpret it in the context of the patient's history and examination, and how we can improve our management. So, if we can tie up all these things together, which I'm sure with these wonderful lectures of Dr. Suresh and Dr. Chinmayee, we'll all be, much more educated. So, friends, I don't want Vaidehi and me to come in between our wonderful teachers. You all know Dr. Vaidehi was the past president of Nagpur Society, and she is one fantastic friend I found in Foxy. So there are so many reasons for you to be active in Foxy. You find brilliant teachers, you find brilliant friends. Chinmayee is one of them. Dr. Suresh is very much a part of our, itinerary that whenever we do some session, we want sir to, make it easy for all of us. So I think that today, what we are going to, understand today is Dr. Chinmayee is going to take us through understanding color Doppler in interpreting FGR and also fetal anemia. So basically speaking, my aim of keeping these talks is simply that the ultrasonologist does not monitor us or guide us in the management. We tell them what we want, and then we get what they are seeing, and then we can give the best care for the patient. With that, I will invite Dr. Chinmayee. Uh, Chinmayee's CV, I think everybody knows Chinmayee. She's in Hyderabad, and she's one of the, in her age group. Another thing I want to tell Vaidehi is teachers necessarily don't have to have gray hair. They only have to have those cells where they are committed to teaching. They are so passionate about learning themselves and then transmitting that knowledge with total humility. And in Chinmayee, I have found this young, fantastic human being in addition to being a good teacher. So, Chinmayee, I'm not reading your CV. I will give the floor to you. Let's start with the session right away. And also in the group, we have the recording of the first session. We'll have the recording of this session. Please spend time to go through these things so that you are more empowered, you understand. And one more announcement today, just now we discussed that there are a lot of gray areas in how to counsel, what test to do, why to do, and all those questions. So in December, maybe we'll bring Dr. Chinmayee and Sir to understand, help us understand counseling in patients of ultrasound and screenings. Thank you. Over to you, Chinmayee.
Thank you. Thank you so much, ma'am, Mitra ma'am and Dr. Vaidehi. I'm really grateful for this opportunity. First, you are giving me a chance to speak on a topic that I just love. And secondly, I'm getting to share this session with a stalwart like Dr. Suresh and such wonderful audience who've already joined in at 8 o'clock and make it all worthwhile, these learning and teaching sessions. So last time we went through the basics of Dopplers. So we understood what are Dopplers, how do we do them, and what each vessel tells us in obstetrics. So when we do a Doppler study, what are we trying to assess? We are trying to assess fetal hemodynamics. Where is the pressure more in the baby? Where is the pressure less? Where are the blood flows going more? Where are the blood flows going less? And how is that affecting fetal function? What are the effects of the maternal changes, maternal blood pressure or maternal health conditions? How is that affecting fetal function? Is there a need for delivery? Because ultimately the obstetrician's concern is whether she can allow the pregnancy to go on or whether she needs to pull out this baby. And if she pulls out the baby, then is that baby going to have an intact survival or there will be some long-term neurological dysfunction? Because today people are not happy just with survival. They are more interested in intact survival. And that's a duty that we have to the next generation to ensure that every child comes out with a good perinatal outcome, with a good long-term neurological function. So one of the important scenarios where the Dopplers help us is fetal anemia. Now, this may not be a condition which each one of you encounter in your daily practice, and hence you might not be so interested in looking at this situation. But let me tell you that I am part of a very important project on fetal anemia, which is on rhesus isoimmunization. And Foxy has been running this as rhesus isoimmunization masterclasses for the last 2 years. And we've realized that there is still a lot of, unmet needs in terms of prevention of rhesus isoimmunization. And therefore, fetal anemia continues to be a clinical problem. Whether we identify it or not and whether we intervene or not at the right time makes all the difference in your perception. Many people think कि हमारे में होता नहीं है. That is because you don't understand and it's already landed up in a kind of fetal abnormality. So whenever the fetus has anemia, there is low hemoglobin and less oxygen carrying capacity in the fetus, which leads to what is called as hyperdynamic circulation. That means there will be a very fast circulation in the fetal system, and this can lead to fetal heart failure and the condition called hydrops. Traditionally, we learned that fetal anemia is detected by the obstetrician when she sees something called sinusoidal CTG. You can see that CTG up there, which has the sinusoidal pattern. But really, looking at a sinusoidal CTG is a very, very helpless situation because you can do nothing by then. And this fetus is already anemic. You cannot deliver a very anemic fetus because, again, that neonate will have tremendous challenges. So the treatment of fetal anemia is timely intrauterine fetal transfusion. That can only happen if you have timely detection of anemia. And this is where Doppler plays an irreplaceable role now, because the middle cerebral artery peak systolic velocity has become a surrogate marker for fetal anemia. And it is so accurate that you do not need to actually do a blood sampling prior to planning your blood transfusion. So the middle cerebral artery is in the fetal brain. And as you can see there on a normal, picture of the transverse section of the fetal brain, you can put color Doppler and see the circle of Willis. The circle of Willis has the anterior cerebral arteries and the posterior cerebral arteries. And you can see a little circle there. And one of the branches that goes along the petrous temporal is the middle cerebral artery. So on the middle cerebral artery, when you put a sample gate like what is shown in the picture on the top of the screen, you can measure the spectral blood flow of the middle cerebral artery, and that will give you the peak systolic velocity. That peak systolic velocity is very high whenever there is a condition like hyperdynamic circulation, which appears in fetal anemia. And this can be plotted. The middle cerebral artery peak systolic velocity in centimeters per second can be plotted on graphs as opposed to this gestational age in which we are. And that is converted to multiples of median. Whenever the value is more than 1.5 multiples of median, we diagnose fetal anemia with a surety of close to 100%. So this is a recent case, and why I'm presenting a very recent case is just to highlight the fact that this condition exists in modern day obstetrics. I practice in a very good city with very good facilities, and this patient has also come from a very good background. So I cannot say that she was, not cared for or she was ignorant of things. But if you see her history, 2014, she had a child. She knew about her research status at that point. She received anti-D at that point. The baby's blood group was positive. She had a termination probably at 5 weeks, which she says in between because of a miscarriage. That time she did not take anti-D. The third pregnancy, she's not very sure whether ICT was done or not done, but she remembers she's taken one more, anti-D after that. So this much history we have. This time she's come with an ICT positive at the time of booking. So at 12 weeks, she was referred to us because the ICT was strongly positive, and we now can do the blood group of the baby in utero with the help of cell-free fetal DNA. So you can send for an NIPT specifically for the fetal blood group. And in this case, it was sent and it was confirmed that the fetal blood group is positive. So we knew that the fetus in utero is at risk because the mother has high level of antibodies. Everything else was normal. So we counseled her that from 16 weeks, we will be doing the middle cerebral artery peak systolic velocity. And we will do this every 2 weeks and follow up whenever there is a need. We will think of a fetal blood transfusion. So you see, this is how we monitor the middle cerebral artery peak systolic velocity and plot it on the graph. Whenever it crosses that red line, we know that that is a trigger for intrauterine blood transfusion. So this patient came to us at 16 weeks. And as you can see, at 16 weeks, the peak systolic velocity was 21 centimeters per second. And at that time, if you plot it on the graph, it is very much well within the normal limits. And at that time, you know that this is not an indication for intrauterine blood transfusion because she's still not the fetus is still not anemic. And let me tell you here that many patients with ICT positive cruise through their pregnancy like this without the fetus actually developing anemia. But in this particular case, she came every 2 weeks. So by the time she was about 23 weeks, we were seeing that the value of the middle cerebral artery peak systolic velocity is close to the 95th centile. And we need to keep a close watch on this in future. And as planned earlier, we again called her. So at 23 weeks, it was about 51 centimeters per second. As a thumb rule, if you don't have graphs and charts, you can remember that for every week of gestation, the 1.5 MOM will be twice the value of the weeks. For example, if it is 23 weeks, then 46 will be the close to 1.5 MOMs. So here it was at 25 weeks or so, it was 50.7, 50.8. And at that point, it came to 1.55 multiples of median. And you see the graph, the value of that just went above the 95th centile or above the 1.5 multiple of median. So now we are at 25 weeks, 3 days, and we realize that this fetus is becoming anemic only based on the Doppler assessment of the fetal middle cerebral artery. And when you look at this fetus very closely, this is a picture of the fetal abdomen. You can see that in between the skin and the liver, there is a thin rim of fluid, which means a very thin rim of ascites is starting. And if we do not intervene at this point, then we will probably land up in fetal hydrops, and that will make the prognosis very bad. So a decision for intrauterine blood transfusion was taken. My point to bring this case here is because only with the help of Dopplers, we could reach the decision of intrauterine blood transfusion. And then when we did the transfusion and sent the first sample for fetal blood group, hemoglobin, and direct Coombs test, we got a positive direct Coombs test, we got a blood group of A positive. And if you can see that the hemoglobin of this fetus was just about 3.7. So that was the anemia which the fetus had, which we diagnosed non-invasively based on the middle cerebral artery Doppler. And look at this picture where you see that just after the transfusion, this is just 25 weeks, 5 days. So the same time when we did the transfusion, we sent the sample for hemoglobin, and the first hemoglobin was about 3.7. That was the pre-transfusion hemoglobin. And after transfusion, the hemoglobin was improved to about 12, but you can see here that the middle cerebral artery peak systolic velocity has come down to 22.5. At the beginning of the transfusion, it was 51, and at the end of the transfusion, it was 22.5, bringing the level back back into the normal range of the MCA peak systolic velocity, and now the baby is no more anemic. So this is, I think, just 1 or 2 weeks back, the date 18th of September, we have done this transfusion. So this pregnancy is currently continuing, baby is doing well, and we will keep monitoring the pregnancy again with the middle cerebral artery Dopplers, and should she develop anemia again, she will have a repeat transfusion based on the current protocols. So the role of obstetric Doppler in fetal anemia is to diagnose fetal anemia, to get the trigger for blood transfusion. And of course, when you do the transfusion, you use color Doppler to monitor the transfusion process overall. And thereafter, to see the completion of the transfusion, also the middle cerebral artery gives us a guide. And then, of course, to complete the rest of the pregnancy. So that's one aspect. I just wanted to run it past you once, because most of you don't think of it in the routine use of Dopplers. But in the current context, this is a very, very potential use of Dopplers. And therefore, please do not forget the middle cerebral artery when you are looking at a patient who is rhesus isoimmunized, or anyone who is at risk of anemia. For example, she has a fever and you suspect a parvovirus infection, or any condition which can lead to fetal anemia. Coming to the common use of Dopplers, which we are all very, very used to, and which we are all very, very passionate about, and that is in growth restriction. So whenever there is a baby who has not achieved its genetic growth potential, we assume that there is fetal growth restriction. And fetal growth restriction can be for multiple reasons. So the commonest reason is uteroplacental insufficiency. When there is very early onset growth restriction without any change in Dopplers, then we get worried, because that may be an inherent fetal problem. So when there are Doppler abnormalities, at least we know that the cause of this fetal growth restriction is more likely to be uteroplacental insufficiency, and this baby itself might actually have the potential to grow. So it is worthwhile now to take care of this baby and bring it out in a condition where it will be having a good postnatal outcome. So last time we dealt with all the theoretical aspects of these Dopplers, but today we will start applying it to cases and understanding how each Doppler helps us in taking a decision at that point in pregnancy. So a 26-year-old primigravida comes to you for first trimester screening. What is the Doppler you do at that time? You do the uterine artery Dopplers. And the uterine artery Doppler is high risk, is high resistance. And at the same time, you have also measured the pregnancy associated plasma protein A, and that is also low, because less than 0.4 mom in first trimester is considered to be low PAP-A. So with a low PAP-A and a high resistance in uterine artery, she is considered as at high risk for preeclampsia and fetal growth restriction. And therefore, we start a medication called low-dose aspirin at the dose of 150 milligrams per day in the first trimester to help in the process of placentation, because the second wave of placentation will happen between 16 and 20 weeks. And if this medication is started early, we will expect the placenta to form better and give a better support to the pregnancy. So in the first trimester, the Doppler that we use is the uterine artery Doppler, and we use it for the purpose of assessing the risk of preeclampsia and fetal growth restriction. So she continued having a follow-up in the pregnancy. At 18 weeks, the fetus was structurally normal. The uterine artery continued to be high resistance, and she continued to take her ecosprin, high protein diet, and all the precautions that we tell her. And we reached what is called 28 weeks of gestation. Now, at 28 weeks of gestation, she comes to us and we do a fetal biometry. The fetal growth is on 5th centile for gestation. So there is a small for dates. The umbilical artery Doppler is high resistance, but it has positive diastolic flow. So if you can see the umbilical artery Doppler, that is the one on the right side of the screen. That is the umbilical artery Doppler, and it is showing high peripheral resistance. I have labeled it as high peripheral resistance. So what is it showing? When the fetal heart is pumping, there is a crest there, and when there is a trough, there is still positive flow above the baseline. So at the end of diastole also, you have positive flow. Last time we discussed the role of umbilical artery. What does the umbilical artery do? The umbilical artery clears off deoxygenated blood from the baby's body to the placenta. So when there is positive diastolic flow, that means the baby is constantly clearing off deoxygenated blood from its own body to the placenta for further oxygenation. The ductus venosus is normal. And what is ductus venosus? Ductus venosus is incoming oxygenated blood. So whatever blood is going from the umbilical artery is being cleared by the ductus venosus, is being cleared by the placenta and brought in by the umbilical vein and ductus venosus, and the baby is getting its own supply of oxygen. The central distribution is normal. The middle cerebral artery is at normal limits. So now you have a 28-week fetus with growth restriction because there is biometry on the lower side and the umbilical Doppler is on the higher side. So definitely there is growth restriction, but the Dopplers are just early changes are seen. It is not critical at this moment. And therefore we realize that there is possibly some degree of hypoxia, but things are getting cleared. There is no central redistribution. Incoming oxygenated blood is good. And there is no obvious problem immediately. So how do we plan to monitor this fetus? She's 28 weeks. She has high resistance in the umbilical artery. And rest of the things are normal. So if you go by the stage-based management, you would like to see this baby after 2 weeks because you want to see how the growth is going on and how the Dopplers are carrying on after 2 weeks. Now, should we consider steroids at this point? Because we know that whenever there is growth restriction, whenever we want to have a preterm delivery, we'll do steroids. Should we give the baby steroids at this point? Now, the role of steroids is to improve fetal lung maturity. You give 2 doses of steroids over 24 hours and expect that in the next 24 hours, their effect will be maximum and it will last for the next 1 week. So if you're not planning to deliver this baby within 1 week, then you should not be giving steroids at this point. And we are not planning to deliver the baby in 1 week, but we are calling the baby after 2 weeks for a review of the Dopplers. And therefore, we do not give steroids at this point. We defer it till we see the baby for the next visit. Now, she is 30 weeks. She comes to us at 30 weeks. Fetal growth has happened, but in terms of centiles, there is a further drop. Now, this will happen. When it was at 5th centile, it might be something like 780 grams. Now it might be 820 grams, but the centiles will drop from 5 to 3 because the expected growth at this point would have been more. So if the centile has dropped, then what you can do is you can go ahead and check for the other Dopplers. When you see the Dopplers, do you see some more changes in the Dopplers? What happened earlier was there was positive diastolic flow. Now there is absent diastolic flow. What happened in the middle cerebral artery? The diastolic flow has increased. So you have redistribution in the middle cerebral artery, but the ductus venosus is still okay. So how is the fetal physiology working now? The clearance of deoxygenated blood has become less. So there will be more pooling of deoxygenated blood inside the baby's body. But the incoming oxygenated blood is still maintained because the ductus venosus is still bringing in incoming oxygenated blood. So baby will be receiving oxygen, but it is not clearing out the deoxygenated blood as easily as it was doing earlier. So there is increased hypoxia. How is that increased hypoxia reflected in the Dopplers? Your middle cerebral artery is showing lesser resistance, more diastolic flow. So vasodilatation in the middle cerebral artery leading to lesser resistance and more diastolic flow is because of the ongoing hypoxia. So now the hypoxia has become more, and because there is no clearance of this, very little clearance of the deoxygenated blood, there is also a higher risk of acidosis. And at the same time, you are worried whether you should deliver or not deliver. She is at 30 weeks of gestation. Again, your question is, should I deliver or should I not deliver? Now, let me put this question to our audience. Suppose you had 4 options, A, B, C, and D. With a question is 30 weeks gestation, growth 3rd centile, umbilical artery, absent diastolic flow, MCA shows redistribution, ductus venosus is normal. Which of the following is the most appropriate answer? A, yes, we should deliver because umbilical artery, absent diastolic flow is an absolute indication for delivery. B, yes, we should deliver because otherwise there's a risk for fetal death. C, no, we need not deliver because there is no immediate risk for fetal death. And D, no, we need not deliver because there is absolutely no benefit of delivery at this stage. So I want you all to think. You have 2 options which says, yes, we can deliver. You have 2 options which says, no, we need not deliver. So obviously it has to be either A or B or C or D. And in A or B, there is a reason given there. Which reason would you think is more appropriate? So you deliver because absent diastolic flow is an absolute indication, then write A. You deliver because there is a risk of fetal death, you say B. You don't want to deliver because there is no immediate risk of death, say C. You don't want to deliver because delivering only has no advantage at this point. Now, can I say how many of you say A, B, C, D? Just put something, whatever you want. So I see a lot of C's and I see a few B's and I see A also. And nobody is writing D. So, okay, so thank you. So it's good to have some division of votes there, but most of you have said C, and I would agree to C because she is at 30 weeks. There is absent diastolic flow, but the ductus venosus is normal. The ductus venosus is the incoming oxygenated blood. As long as oxygen supply is there, there is no immediate risk of death. So there is no immediate risk of death, and that is why the answer is C. Why is the answer not A? Because it is not an absolute indication. There is no absolute indication for delivery under any circumstances with Dopplers, and we'll see that later why. Yes, there is a risk of fetal death. Well, there is always a risk of fetal death. Life itself is a risk of fetal death. So that cannot be an indication for delivery at this stage. And D, there's no benefit of delivery absolutely can be argued because if you have a very good NICU, they might argue that we would like to deliver this baby. Now let's look at it why. So the situation we had was that she was 30 weeks. There is absent diastolic flow. There is very high peripheral resistance. There is central redistribution. There is good incoming oxygenated blood. Should we deliver or should we not? So I think the answer is no. There is no urgent risk for need for delivery, but there is a risk of fetal acidosis because there is absent end diastolic flow. Now your option D was there is absolutely no benefit of delivery. The benefit of delivery is you will prevent further acidosis. So if you have a very good NICU, state-of-the-art NICU, and the neonatologist is very comfortable with a 30 weeker, then you can talk to them and say that, look, our outcomes at 30 weeks are very good. And because we are further, risking acidosis, we might consider delivery at this point. Because once acidosis sets in, the baby can have what is known as hypoxic ischemic encephalopathy grade 2 or 3. The hypoxic ischemic encephalopathy grade 1 is a reversible process and does not usually lead to long-term neurodevelopmental outcomes. However, if the grade 2 or 3 hypoxic ischemic encephalopathy sets in, there can be long-term damage. So if it is a 30-weeker with an absent diastolic flow and your NICU is very keen, the parents are very keen, everybody is happy with that thing, you may consider delivery. So that's why you cannot write D because there is no absolute benefit for delivery. There is sometimes benefit and therefore you may consider that at some point or the other. But whether you will deliver under all circumstances, no, it's not that way. So there are pros and cons and you have to go through this discussion with the parents, with the NICU and with everybody at that stage to take that decision. So should we deliver? Should we wait? We are still in doldrums. We right now think we should wait. Are steroids to be considered now? I think yes, because you have an absent diastolic flow. You don't know how soon this is going to, get worse, and you will call this woman for, repeat Dopplers every weekly or at least twice weekly because you need to see how things are progressing. So if you're not delivering her immediately, also you're calling her in 3-4 days time because you think it might get worse, and if it gets worse, you will consider delivery. So here we would give off the steroids. Now we gave the steroids, and we anticipated this kind of a progression of placental disease, a slide which we have gone through in the last session, because we have realized that our Dopplers, the role of Dopplers, it corresponds to some level of placental insufficiency. So when the umbilical artery is high resistance, you have very mild placental insufficiency, which only leads to hypoxia. But when the umbilical artery becomes absent or reverse diastolic flow, by that time you are transitioning from hypoxia to acidosis. And if it continues to be like that, you may have ductus venosus changes and finally leading to fetal death. So you don't want to have a fetal death under your watch. You want to wait and deliver exactly at the right time that would be appropriate. So with all this delivery, with all this counseling and follow-up, she's now reached 32 weeks. At 32 weeks, your umbilical artery has now started showing reversed diastolic flow. So as long as there was positive diastolic flow, we were sure that the deoxygenated blood is getting cleared out. When there was absent diastolic flow, we realized that it is not getting cleared out intermittently. But once there is reverse diastolic flow, the deoxygenated blood is also coming back to the system and piling up in the system much more. The MCA had redistribution, so whatever is the hypoxia is continuing. The DV has become high resistance now. That means the supply of oxygen is not so well forward. How it was earlier, it has now become less than that. It has become suboptimal. So the incoming oxygenation is suboptimal. The outgoing deoxygenation is very, very suboptimal. We are in a bad situation now. Liker is only 4, AFI is 4. So when does the liker come down? When this kind of redistribution brings down the blood supply to the fetal kidneys. So when the fetal kidneys are hypoperfused, the GFR decreases, the urine output decreases. So the urine output decreasing is a sign of renal ischemia. And the biophysical profile is 6/8 with reduced fetal movements. Now, biophysical profile and CTG, these are all adjunct methods of monitoring a fetus in distress. A fetus which is growing less, a fetus which has bad oxygenation is in distress. So you need adjunct mechanisms to monitor them. And there is no one method of monitoring that is above all. So you will have to put everything together and see. When there is reduced fetal movements and the biophysical profile has started to diminish, you realize that the baby's nervous system is now responding and it is actually becoming sluggish. And now you may consider delivery because it is 32 weeks, Dopplers are getting bad, the overall situation of the baby is bad. So you really need to consider delivering this baby based on the discussion that we have had so far. Suppose you had not given steroids earlier, this was the best time to give steroids because you are anticipating delivery shortly. But if you've already given steroids, the decision to repeat the steroid is a consultant-led decision, and there is no real consensus on whether you should repeat it after 2 weeks or not. But that will be a discussion between the neonatologist and the obstetrician, and then you take that call. But you think of delivery. You think of delivery, you explain that to the patient, but sometimes patients will say, Madam, baby is only 1 kg. Why do you want to deliver now? I don't want to deliver now. This is too small. My mother-in-law is not agreeing to deliver now. My husband says, let's wait for 2 more days. Please wait for the eclipse to be over. Please wait for, my uncle to come back from USA. So there will be hundreds of reasons why she may or may not agree. If she does not agree to deliver now, then what do you do? Is there a 100% indication that we have to deliver? Is there a risk of fetal death immediately? No, there is no risk of fetal death immediately because the ductus venosus is still normal. But the situation has started to worsen. So how do you counsel this patient? And that again is an exercise that you have to do. When you talk to the patients, you explain to them all these problems and you tell them that, this baby is getting sicker and sicker inside. If we don't deliver the baby now, there might be changes that happen in the baby which may lead to long-term neurological injury. And therefore, the advantage of delivering this baby now is more than keeping the baby inside. What we will gain in terms of maturity will be offset by the damage that will happen inside. And therefore, you may have a baby which is a little more mature, but at the same time, there might be neurological injury. Then again, if the baby started to move slow, we don't know when exactly it's going to get compromised. So I don't have a timeline for that. And if you continue, probably you have to accept the fact that there could be an in utero fetal demise, which we may not be able to predict completely. So that counseling has to be complete at that point. So how the Doppler helps you is in explaining to you what is the physiological situation of the baby at this point in time and how you can tune your clinical management and give the patient a good outcome. Sometimes when you don't find yourself completely adequate in explaining this to the patient, you can go for online calculators. This also I showed you last time in the thing, but I'm just explaining to you in a little more detail today that you put in all the necessary details of your clinical findings. This is an online calculator which tells you that there is reverse diastolic flow in the umbilical artery, even in the absence of maternal preeclampsia. The middle cerebral artery PI is reduced. The ductus venosus is showing a positive diastolic diastolic flow. The deepest pool is about 2 centimeters. And we see that there are no decelerations in the CTG yet. At this point, consider steroids and delivery, because you don't want to wait for that last parameter to get spoiled, because you're at 32 weeks of gestation. So this is how you can take decisions based on Dopplers, because you have understood the pathophysiology of growth restriction. You have understood that the Dopplers are reflective of the fetal function. They will therefore play an important role in the decision for delivery. But you may have to constantly revise your plan depending on what is happening to the mother, and when necessary, you can take online assistance. So when you look at the Doppler changes, again, something which we discussed last time, and we promised that it will be a continuum of understanding. So forgive me for repeating some facts that we actually went through last time. But unless we keep repeating them, it will not get stuck in our brains. And therefore, what starts with umbilical artery problems, which are a signal of peripheral problems in the baby, then lead to central redistribution in the form of MCA peak systolic MCA pulsatility index reducing. So you see that the flow in the umbilical is very high in the diastole in the beginning, but it becomes low and reversed in the end. The flow in the diastole is actually less in the beginning in the MCA, and it becomes more when the redistribution happens. And in terms of the ductus venosus, we discussed the 3 waves last time. The A wave disappears and then becomes reversed. So what is the ductus venosus doing? The ductus venosus is bringing incoming oxygenated blood. And when the A wave is absent and reversed, your oxygenation itself is suboptimal. So those are the late changes in terms of Dopplers. Suppose there is a mother who has a history of hypertension and who has a history of epilepsy. How do you deal with that? She comes at 28 weeks. You see that the estimated fetal weight is on the 5th centile. But the Dopplers are normal, so you call her back after 2 weeks because she has all these medical conditions in the background. Now the estimated fetal weight is on the 3rd centile. So what do the Dopplers tell us at 30 weeks? She has positive diastole. Now I just want you to see through these Dopplers. The first one is the umbilical artery Doppler. It is showing a positive systolic flow, of course, and a positive diastolic flow. That means it is clearing off the deoxygenated blood in time. Then you have a middle cerebral artery, which is okay, and you have a ductus venosus, which is also okay. So hemodynamically, this baby is fine. It is small because estimated fetal weight is on the 3rd centile, but hemodynamically, it is normal. So at 30 weeks of gestation, we are not discussing delivery with this person. But at 32 weeks, when she comes back, what has happened? The umbilical Doppler is now becoming absent and reversed. So you see reverse diastolic flow in the umbilical artery. You see high diastolic flow in the middle cerebral artery, and the ductus venosus is still normal. But your gestation age is 32 weeks. So you have now reached 32 weeks of gestation. There is a small baby. There are major changes happening in the umbilical artery. You should consider delivery, and you can consider corticosteroids and NICU planning, because at 32 weeks, most of the NICUs will be happy. Why don't you want to continue further till 34 weeks or 35 weeks? Because again, remember what we discussed last time. When the umbilical artery is absent or reversed, what is happening? The peripheral blood supply of the baby is compromised. So the blood supply to the gut, the blood supply to the limbs, the blood supply to the peripheral organs of the baby is compromised. And in preterm babies, these are the babies which will be at higher risk of necrotizing enterocolitis and complications which will otherwise make the prognosis worse. So in a good NICU, the neonatologist will probably tell you that if you have to give me a small baby, don't give me a sick small baby. Just give me a small baby and I will make it better. So you need to have that discussion with the NICU team, and they may consider delivery. So this was again something we discussed last time, the stage-based management. So if you see here, starting from 26 weeks, you look at your endpoints in Doppler parameters. At 26 weeks, you will probably wait for the last change in the ductus venosus because you are desperately trying to hang on for some maturity. But when you come to 37 weeks, even high resistance in umbilical artery, the slightest change will indicate the need for considering induction at that point. At 34 weeks, absent diastolic flow can be considered an indication for delivery. At 30 weeks, you may wait for early changes in the ductus venosus because you don't want to have a preterm delivery without having any reason for intervening at that point. So always balance the risks of prematurity with the risks of stillbirth. Now, this paper is a very, very important paper. And like I told you last time, it is freely available on the internet. If you want to read it, you are more than welcome. If you want me to send it to you, please tell me. I can send it across to you. But the important pearls of wisdom that this paper gives is that umbilical artery is a very, very important Doppler. And therefore, please do not do any growth scans without doing at least an umbilical artery, because it's an only parameter which has diagnostic as well as prognostic information for growth restriction. However, as a standalone parameter, it is not valid. You should always look at the Dopplers in combination before you take a decision. MCA redistribution is a surrogate marker for fetal hypoxia. And when you are in doubt, the combination of MCA and umbilical artery, that is the CPR, works better than the MCA alone. But ductus venosus abnormality is the single strongest marker for short-term risk of fetal death. So if ductus venosus is abnormal, then you will probably not continue the pregnancy. So quickly, another early onset IUGR for you. This is a woman who has a very, very difficult pregnancy, and she had an IVF conception, and a little elderly woman, and she was referred actually for echogenic kidneys. I'm running through this because that is not the point what I want to make. Her kidneys eventually turned out to be okay, but at 29 weeks, 2 days, she came with severe preeclampsia. So now this is a pregnancy where the Doppler changes may be secondary to the maternal preeclampsia. So mother has preeclampsia, kidneys are now looking fine, but the growth of the baby is less than first centile, and that is because of uteroplacental insufficiency that is secondary to her preeclampsia. So the baby's growth is very low, and the umbilical artery Doppler at this point shows positive end diastolic flow. The MCA shows some redistribution, and the DV is normal. So we don't deliver right now because umbilical is still positive diastolic flow. AFI was normal. We called her back after 1 week, and at 30 weeks, suddenly the umbilical artery has become grossly abnormal. So like in the last 2 cases you saw, as long as the maternal parameters are stable, things will go in a good manner. But when the maternal parameters are unstable, there may be sudden deterioration of the Dopplers. So at 30 weeks, 2 days, there is absent and reverse diastolic flow of the umbilical artery. And this is a really risky situation. She can have an IUD. And after considering a joint discussion with the NICU team, our NICU said, deliver the baby. We are happy to take care of the baby. Do not prolong it inside. So we delivered this baby after giving steroids and neuroprotection. And she delivered a 1.1 kg baby who had an Apgar of 7 and 8 in the newborn period. So transferred to NICU, lived in the NICU for almost 4 to 6 weeks, but finally went home happily, and everybody was happy. Now, this is the story which we see in early onset IUGR. A quick word in late onset IUGR, and I will pack up thereafter, because the Doppler changes that I have told you are very characteristic of sequential changes in the placenta. But there is a new kind of IUGR that we have found now, which is called the late onset IUGR. The problem with late onset IUGR is you may not even diagnose it, because all late onset IUGR babies may not be small for dates also. So the baby may be 10 centile or even 12 centile, but it may have late onset IUGR. And the Dopplers are not that bad because you don't have that level of placental dysfunction. So the diagnosis of late onset IUGR is extremely difficult, and for that you need to have serial monitoring of fetal growth. So if you look at this chart, the growth is still within normal limits. It is still above 10 centile, but it has come down from what it was in the mid pregnancy state. So this is called late onset IUGR, and the difference in the placenta in late onset IUGR is placenta is very well formed. So you have a placenta which has lot of villi, and therefore the umbilical Dopplers will not change that much. The placental resistance does not change that much. In early onset IUGR, you see the villi, they are so bald. You will have very small placenta and you will have huge changes in umbilical artery. So in late onset IUGR, you will not have changes in the umbilical artery, but there will still be hypoxia. So that will be manifested as mild changes in the middle cerebral artery and mild changes in the umbilical artery. Individually, they may not be very pronounced, but when you look at the combination of the two, that is the cerebroplacental ratio, that will be grossly altered in the late onset IUGR. So to give you a very baseline example for the two, early onset IUGR is like student A. Student A is a very poor student. You look at his grades, always gets C, D, C, D, C, D, and everybody knows that this baby doesn't do well. And finally, in the final exam also, he has passed with 47 out of 100. Somehow he has passed. He has low grades. Everyone knows, they take tuitions, they take extra classes, and this child passes. But the late onset IUGR is like student B, always scores A in the things. Somehow at one point he scored B, nobody cared for it. They thought it's okay. He got distracted for one term, not a problem. But thereafter he got a C and finally he got an F and failed the final exam. Now in early onset IUGR, suppose this child had failed also, people would not have minded it so much because it was an anticipated problem. Whereas in the second type, it is an unanticipated problem. You have just misread one shift in baseline, and this child actually failed the exam. So late onset IUGR is like that second student where there will be an unanticipated IUFD. So you might have a 2.5 kg baby with an IUD at term. You think there is no IUGR, but this baby was destined to be 3.5 kg. And therefore, there was a shift in the baseline and it has now become 2.5 kg. So late onset IUGR, the way you look at Dopplers is different. You don't look for absent diastolic flow in late onset IUGR. You look for changes in the cerebroplacental ratio in late IUGR. And this is IUGR that starts only after 32 weeks. So when you have a 32-week scan, you can help in diagnosing the late onset IUGR. So for fetal growth restriction, early diagnosis, appropriate monitoring, and timely delivery is the most important thing. And therefore, Dopplers help us in achieving that goal without compromising on the perinatal outcome. So with that, I will rest my case here. Thank you very much for a very, very patient hearing. Sorry if I overshot my time.
That was actually brilliant. Your analyses are always so self-explanatory, but I'm so sorry, Chinmayee, because these topics are wonderful and we have Sir also with us. So
Yes,
I
yes.
will, without much, we'll invite Sir so that we can, learn from him as well. That was
Thank you.
brilliant and
Thank you so
fantastic.
much.
Over to you, Vaidehi, for Dr. Suresh, sir.
Yeah, thank you so much, sir. Moving on, dear friends, it's time to welcome the teacher of teachers, Dr. Suresh, sir. The one person, the master who revolutionized ultrasound in India and shaped all of us along the way. Sir, it's an honor to have you here today. And sir is going to cover Doppler studies in anomalies. Sir, our attention and stage is all yours.
Yeah. Just 1 second. I'm just going to
Sir, I
share.
want to just put in a comment till you are getting your slides in
Yes,
order.
yes,
I
yes.
want to tell you, sir, that for us, you are the Nicoloides.
Are
You
you?
are all the big
No.
wigs from
No.
outside because
Oh,
you,
don't say such big things.
no, sir, you are giving us data of our own people
Yeah,
and you are inspiring all of us to learn to look at our babies more closely with understanding.
yeah.
So,
And
Okay.
thank you, sir.
we also want to congratulate you for being getting elected as the treasurer of ISOG.
Yes.
So, sir, congratulations once again.
Thank you. Thank you for that. So I'm going to give you Doppler in some special conditions. Anemia already been covered. So placental issues, anomalies, and twins. The whole thing is to understand about some additional aspects of placenta and twins. So what we'll do is I'll just give you this anemia which has been talked about. We have immune, non-immune anemia, and we also have the reason for non-immune anemia being infections, genetic, and other causes. And the other causes become quite important, like chorioangioma, TTTS, TAPS, AV malformations, fetal hemorrhage, etc. And these things need to be actually identified appropriately and managed appropriately. We can also have severe anemia in parvovirus infection, where baby is looking otherwise normal. Suddenly you have polyhydramnios, and whenever there's polyhydramnios, an MCA Doppler must be done for any patient to rule out anemia as one of the causes for polyhydramnios. Now, let me take you through chorioangioma. Now, chorioangioma can be large or small. When you see any chorioangioma beyond 5 centimeters in diameter, we call it as a giant chorioangioma. And less than 5 centimeters, we don't call it as a giant chorioangioma. So here, once you see a chorioangioma, you have to switch on the color Doppler and see its vascularity. And the vascularity is very variable, because you can have mild vascularity or you can have very significant vascularity. So if you say the entire vessels are occupying the entire chorioangioma, then we call it grade 4 vascularity. Now, why are we interested in this? Because the vessels in the chorioangioma, from the umbilical cord, you can see an artery going inside the chorioangioma, and then the vein will take it back to umbilical vein. Because they are very, very close to the umbilical cord, you will find that the artery and the vein are anastomosing each other in the chorioangioma. It acts like an AV malformation. And when it acts like a AV malformation, the venous pressure goes very high. There's a huge load on the heart, and the baby can go into cardiac failure. So you can have cardiomegaly and tricuspid regurgitation. So in about a quarter of the babies with chorioangioma, you will have anemia, and you can see cardiomegaly there, cardiac compromise in about a quarter of them. And you can have tricuspid regurgitation, which all these of course need Doppler, and turbulent venal hyperdynamic circulation in about 17%. So these are the moment you see a chorioangioma, we not only look at the chorioangioma, but we also look at MCA-Doppler, we look at cardiac Doppler, and also we look at venous Doppler to ensure that to understand what is the level at which what are we supposed to do. So we find that, as I told you, when the tumor size is less than 6 centimeters, you usually have, most of them are live born. But when it's more than 6 centimeters, 25% can actually go into IUFD. So one of the important things of doing color Doppler and continuously monitoring them over a period of time is a chorioangioma is looking quite vascular in early pregnancy. When you switch on the color later in pregnancy, when it becomes hypoechoic, it can become completely devoid of vasculature by itself without us doing anything. And this is because I think the tumor outgrows its supply, and or spontaneous thrombosis happens inside, and that can be demonstrated by a color Doppler. So spontaneous cessation of vascularity is something we can do. Of course, what we can do is we can do interventions. There are several interventions that are done. Intrauterine transfusion is one of the interventions for correcting the anemia, and we can give what is called as histacryl glue inside, which can also give you cessation of flow inside the chorioangioma. Other anomalies that can cause fetal anemia are sacrococcygeal teratoma and vein of Galen malformation. These two are ones which will definitely a potential cause of cardiac failure and also severe fetal anemia. So why are we doing color Doppler anomalies? To identify specific vessels and structural defects, to identify vascular abnormalities, and also could be a primary or an adjunct to diagnosis, right? So here example, I'm going to show you a picture with a normal baby with the aorta. You can see I've taken a coronal view, and I'll tell you why we have done the coronal view. You can see the abdominal aorta branching off into the two iliac vessels. And then right in the lumbar region, you can see two vessels which are going on both sides. So these are two vessels. One is going towards the probe, red in color, away from the probe, blue in color. These are two renal arteries. The presence of two renal arteries tells you definitely the kidney is there. Okay. Now, as compared to that, here's a baby, which you can see that I can see the aorta, but I'm not able to see any renal arteries on both sides. So this is the case of bilateral renal agenesis. Before the advent of color Doppler, we actually used to give intraamniotic saline, and then because there'll be severe oligohydramnios, we do intraamniotic saline and even intraperitoneal saline injection to demonstrate absence of kidneys. But today we don't do that. We look for the lying down adrenal and absence of renal arteries on color Doppler. So the advent of color Doppler changed the way we diagnose renal agenesis. Then, of course, we have pulmonary sequestration. So when you see an echogenic mass, which is either in the thorax or just immediately below the diaphragm, one may think this could be an adrenal tumor, but this echogenic mass, we should always try to rule out an extralobar pulmonary sequestration. And what happens in color Doppler and how do you prove that it's an extralobar sequestration is carefully watch this vessel, watch this clip. So what I've done is you've seen the abdominal aorta here, and you can see a vessel coming out of the abdominal aorta and supplying this lesion. Okay, so this is actually a pulmonary lesion which is supplied by the abdominal branch from the abdominal aorta. So that's why it's a systemic supply, and that's why we call it as a pulmonary sequestration. It is sequestered from the normal lung and it gets its supply from another vessel, which is the systemic vessel. Then color Doppler in cardiac anomalies. We do for screening, diagnosis, and both the inflow and the outflow tract anomalies. So whenever we do heart now cardiac examination, of course we have to do the B mode right from the first trimester to second trimester, but we also have to compulsorily do color as part of a routine screening. Color Doppler once, which was supposed to be used only on indication, today we do even for routine screening as per ISWA guidelines. You have to switch on color Doppler because there are hardly any machines without color Doppler now. So when you take the 4-chamber view, the important thing about doing the color Doppler is that when you do the 4-chamber view, you have to adjust the PRF in such a way that you have both the inflows are seen well with a good separation of the interventricular septum. So you adjust the PRF, you adjust the gain like we told last time, and then we do that. The moment you do that, you sweep your probe upwards, and then you see these two blue lines which are coming through in the shape of a V, right? This inverted V shape which is there is otherwise called as a tick sign, where you see a long ductal arch and a small aortic arch. So ductal arch and aortic arch together, and this is your transverse arch. So this uniform color of both of these tells us that both the outflows are going in the normal direction, the flow is coming away from the heart, and there is no outflow tract abnormality. So here, if, for example, if there's a hypoplastic left heart or the right heart, you will see reversal of flow in the ductus because it becomes a ductus dependent circulation. Now, the other thing, of course, is in your 4-chamber view, we do a Doppler, a pulse Doppler at the tricuspid valve and the mitral valve. So this typical M pattern of the tricuspid valve should be documented because tricuspid regurgitation can be identified using color Doppler. So here is a hypoplastic left heart. You can see there's no color on this side, whereas there's only color on the right side of the heart. And you see the outflow. If you carefully watch the outflow, you can see there's only one outflow which is coming out, right? And the little red which you're seeing here, that's a reversal of flow in the ductus arteriosus, which comes as part of this package. So hypoplastic left heart, similarly hypoplastic right heart, you can see the left atrium, left ventricle is normal, the right ventricle is very small, and when you switch on the color, you can see flow only on one side. This gives you a confirmatory diagnosis that this is a hypoplastic right heart. Right. Then we've seen already. Then when you look at Doppler, when you want to do Doppler, we have seen uterine, umbilical, middle cerebral artery, ductus venosus. And when you do it in twins, we find that Doppler in twins is exactly the same way we do Doppler in singletons, but the interpretation of Doppler in monochorionic twins is very, very different as compared to dichorionic twins and singletons. So just before I go into Doppler into twins, I'll tell you a little bit about a couple of more anomalies before we move forwards. One of them is called vein of Galen malformation. And the reason why I'm bringing up this abnormality is in almost all cases, the second trimester target scan will be absolutely normal. When you come to the third trimester, suddenly you will find that even in the third trimester, you do a scan at 30 weeks, absolutely normal. When you rescan at 34 weeks, suddenly you will find a cystic area which is in the brain. And that cystic area, if you do in real time, you will see blood swirling inside. And it will always be seen in the midline, more posteriorly. So this is called as a vein of Galen malformation. So you can see that's a sagittal vein. You can see the blood swirling inside on the Doppler. And when you do the color Doppler, you can see the enormous amount of flow which is there. Now this, because it's an AV malformation, is going to cause venous flow into the heart, and baby will have cardiac failure, which can happen very quickly. Now the next is in the brain. When you do color Doppler, when you do a mid-sagittal view, this is the picture of a normal fetus with a mid-sagittal view, where you can see the corpus callosum in the middle, and this vessel which is there is the pericallosal artery. So the presence of the pericallosal artery tells you that indeed the corpus callosum is fully developed. As compared to here, where the corpus callosum is absent, you can see the pericallosal artery is missing. So using color Doppler, we can confirm the diagnosis of agenesis of corpus callosum. Right. Then in the abdomen, you always look for this is the section of the transverse section of the abdomen at the level of the abdominal circumference. And this, all of us know, it's the umbilical vein and the C curve of the portal vein. But what happens is the umbilical curve normally, what it has to go towards the left side, isn't it? So here you can see the vein going, there's a persistent vein which is going more towards the right side, and it's going in the side of the gallbladder, where you can see that this is a persistent right umbilical vein. Then when you see umbilical vein abnormalities, where the umbilical vein is coming here, normally the umbilical vein is supposed to go to the ductus venosus and then connect to the IVC, where here you can see the umbilical vein going directly into the right atrium instead of going through the ductus venosus. So it is called a direct entry of the umbilical vein into the right atrium. Here you can see the IVC which is coming up here and then reaching the heart. So this is also one of the venous anomalies that we can do that. But another important anomaly which we can find out on color Doppler is when you do a cross section of the abdomen, sometimes you can see a cystic area in the abdomen. Now in the abdomen, when you see cystic areas, we think it's the stomach, it's the bladder, or it could be any other intra-abdominal cyst which is there. But it's extremely important that whenever you see a cystic area, you have to switch on color Doppler. And so let's see what happens when you switch on the color Doppler. We can find that cystic area is actually not only having flow of blood, but inside you can see a venous pattern of flow. So this is classically an umbilical vein varix. Now, why should we know about umbilical vein varix? Because first of all, you define umbilical vein varix when the intrauterine and the umbilical vein diameter is more than 9 millimeters, and the transverse diameter of the focal dilated intra-abdominal portion of the umbilical vein is at least 1.5 times greater than that of the intrahepatic umbilical vein. So you take the umbilical vein size for the baby. If this size is more than 1.5 times, then you can call it as an umbilical vein varix. Because why? There are associated problems which we need to do: cardiovascular abnormalities, diaphragmatic hernia, ventriculomegaly, short long bones, and these are all being associated with umbilical vein varix. But you can have isolated umbilical vein varix. So among these, the one with isolated umbilical vein varix, 8.1% resulted in intrauterine death in an otherwise normal pregnancy. Extremely important, because these are the ones which we follow very closely, and then we can potentially have sudden IUD which can happen to do that, because sudden thrombosis happens in the vein. So fetal cardiac failure has been proposed as a cause. The other potential mechanism is very predisposes to umbilical vein thrombosis. Right. So renal imaging, we have seen that. Unilateral renal agenesis, you can see that only one side the Doppler is there, and the other side the renal artery is absent. Now another advantage we have is here is a transverse section of the thorax where the right lung is there and the left lung looks enlarged. And so this means this could be a possible congenital pulmonary airway malformation. But however, when you do the color Doppler, we find that this vessel is the abdominal aorta. So you can see the baby in the coronal view. You can see the ribs there, and this is the coronal view of the baby. This is the abdominal aorta, and the branch from the abdominal aorta, which is the superior mesenteric artery, instead of going downwards towards the abdomen, towards the bowel, it's actually going upwards towards the lung. And so obviously what has happened is the bowel has migrated into the thorax. So the SMA is actually upturned. And that's how you differentiate between a CPAM and a diaphragmatic hernia. So the diagnosis here is not CPAM, but it is diaphragmatic hernia. And we do that by looking at the upturned SMA. So the other thing in diaphragmatic hernia that happens is when the liver rotates, the umbilical vein, instead of going straight towards the spine, it deviates in a curved fashion. So a deviated umbilical vein and an upturned SMA both are diagnostic of diaphragmatic hernia. Then, of course, in abdominal wall anomalies, you can see gastroschisis. In gastroschisis, you can see there is a para-umbilical defect where you can see the bowel is floating here, and the umbilical vein is actually entering in its normal location. So the defect is actually outside of the umbilicus, or para-umbilical, and it is not. Why are we looking at this? Because you can differentiate this from an omphalocele, where you can see the omphalocele and the umbilical cord is attached on top of the omphalocele, because the omphalocele is actually bulging into the umbilical cord, and that's why the umbilical cord here is on top. So location of the entry of the umbilical cord gives you the diagnosis between the omphalocele and gastroschisis. Then here we have a fetus which appears that both lower limbs are fused with each other, and in this you will have the aorta which is coming down, and it will not bifurcate into two vessels. It will be a single vessel which is going through. That's what is called as incyromelia. Now, we have already seen sacrococcygeal teratoma, but just a few more words about it. Sacrococcygeal teratoma can have a vascularity which could be minimal, or it could be very significant. Not all sacrococcygeal teratomas will have anemia or cardiac failure, but this is the potential area. But the important thing about sacrococcygeal teratoma is, while in chorioangiomas and other AV malformations, we have been able to do interventions by giving either histocrel glue or radiofrequency ablation or interstitial laser. We have done quite a lot. But in sacrococcygeal teratoma, unfortunately, none of these methods seem to work, and they seem actually to cause more problems than success. So because the vessels which are supplying are quite multiple, it's not a single vessel which is supplying the chorioangioma, and ablating all these vessels is going to be a very, very difficult process. So that's for sacrococcygeal teratoma. Then a few words about vascular problems in twins. So here, so what I'm going to do is, let me talk about twin transfusion. Okay, in this we need to understand what is called as the vascular angio architecture of the placenta. So here you can see the two cord insertions, And then what's happening is there is a single placenta. There are two umbilical cords attached, and these vessels, the umbilical artery and the vein, go inside and supply each of these cotyledons, right? And then there are also connections deep in the cotyledon, because this is the shared cotyledon, for example, where the umbilical artery of one twin is anastomosing with the umbilical vein of the other twin. And you can also, these are deep in the cotyledons. And here you can have a superficial artery to artery anastomosis and vein to vein anastomosis. So there are three types of anastomosis here. And also here, one of the important things, which for it's a clinical practice point, is whenever you see any fetus, make it a habit to map cord insertions. Okay, here you can see a marginal cord and a central cord. Here you can see a velamentous cord and it's a marginal cord. And here a cord which is very, very close to each other, which is called as proximate cord insertions. So you can have central, paracentral, marginal, velamentous cord and doing that. So you can identify cord insertions by using color Doppler, and we must make it a habit to do, especially in monochorionic twins. Everybody must map cord insertions and insist on the report of cord insertions, because any velamentous cord will have implications on the baby, like growth restriction because of poor placental sharing in that area. Then here are two cord insertions. They are very close to each other. Now, if this baby develops twin-twin transfusion, we cannot do a laser in this case. So cord insertions are very, very important. So let me move on. The various types of us, we won't go deep into the vascular anastomosis, but just to say that the arterial anastomosis which are there in the superficial part of the placenta, if there are a number of AA anastomosis, they help in preventing TTTS from happening, right? And to identify arterial anastomosis on Doppler is actually a tough task, right? And these arterial anastomosis do what is called as a balancing act. It takes away the pressure from one side and pushes to the other side. And unfortunately, today we don't have the technology to map all the AA anastomosis. So here is an example of an AA anastomosis which you see on the surface of the placenta, and you can see the flow up and down on both sides, and the presence of it actually is very much helps us. Then we also have what is called as a vascular equator. Now here's the placenta, you can see the membrane, but beyond the membrane you can see this area where the vessels of this fetus and this fetus are anastomosing with each other. So this whole thing is called as the vascular equator of the placenta. So this vascular equator is also important for us because we see it only with, we cannot identify the vascular equator with Doppler, but we certainly see it with the fetoscope, which is used for when you do the laser. But more importantly, when you have a monochorionic twins with discordant for Leica, and any monochorionic twins, irrespective of what the Leica is, we must look at both the baby's hearts, because the first thing that happens in TTTS is volume overload. And the volume overload, you can see a dilated heart, you can see tricuspid regurgitation and cardiac function compromise, which is there, which may predispose all other things in TTTS, all other findings in TTTS. So how do we do cardiac function? By doing Doppler of the heart, which is called as myocardial performance index. I won't go into the details of how to do the myocardial performance index, but certainly when you do across the tricuspid valve and the mitral valve, we do the right-sided myocardial performance index and the left-sided performance. It helps us to prognosticate. So this is the donor myocardial performance index, and this is the recipient myocardial in stage 1, stage 2, and stage 3 TTS. So you can see all these stage 2, the average is about 0.45 to 5. In recipient myocardial MPI has gone to 0.59 and 0.61. Other Doppler parameters which we use is IVC, ductus venosus, presence of an A-wave reversal in ductus venosus, like it happens in IUGR. Here it signifies huge volume overload, and baby is at significant risk. Now, the other thing is it also helps us to score the scoring system in TTTS based on the Doppler parameters. We don't want to go into the details. Then, of course, when you're looking at twins with possible TTTS, and there are various stages, we won't go to the stages, but all I'm trying to tell you is every monochorionic twin requires 2 weekly Dopplers of umbilical artery, MCA, and the ductus venosus to be done. And this is what is important because here is a baby with twin transfusion syndrome, and we find the Dopplers were normal on both sides, and we call it as stage 1 TTTS. And then we follow up the patient, the Dopplers continue to be normal, then we don't do anything for the pregnancy, and she's already reached 29 weeks now, and we'll be able to we deliver her at 34 weeks. So both babies are doing it. So the presence of Doppler in management of twins is very, very important. But also remember, because of velamentous cord insertion, twins can be associated with selective fetal growth restriction. And that here you can see there's a growth discordancy of 60% between one twin and the other twin. And your Doppler here, it becomes very important because here you can see that smaller twin is having reversal of flow in the umbilical artery, and this is continuous reversal of flow in all that. So this is called as type 2 or type 3 type 2 selective fetal growth restriction, right? So which means this baby requires a procedure, and then the 3 days after the procedure you can see the other baby ascites has gone and the Dopplers are returning back to normal, right? So then the last but one, because I'm seeing the time is running out, we do what is called as, we need to identify one thing of twin reversed arterial perfusion sequence. The criticality of Doppler here is that when you see a twin pregnancy and when you switch on a Doppler, it is important to understand the red and the blue, right? So here I'm seeing a fetus here, and you can see the baby is moving so vigorously. But when I get it to an appropriate position, so let's see, let me try to get a, okay, so here you can see that this is a normal fetus where you can see the aorta and the umbilical artery which is going away from the fetus. So that's blue in color, right? Now, on the other hand, let us look at this fetus, right, where the umbilical artery is actually going into this fetus. So this is a reversal of flow in the umbilical artery, which is called as twin reversed arterial perfusion sequence. And that umbilical reversal tells, of course, this baby will also be having a cephale and a cardiac, and you can easily recognize it even on B mode. Then in a twin pregnancy, when one baby is small and the other baby is red, color Doppler becomes very important. As I said, the presence of cord insertion. Here you can see a velamentous cord insertion, and this is a central cord insertion. These two must be mapped.
Start to see much smaller portion.
And we use serial Dopplers to map how these things are going. And when we do the umbilical artery Doppler, the way we interpret umbilical artery Doppler in monochorionic twins is completely different from what you do for a growth restricted baby in singleton pregnancy. Here, when you have continuous forward flow in all, we call it as type 1 selective growth restriction. When you have a persistent absence or reversed end diastolic flow, you call it as type 2 growth restriction, SFGR. And when you have intermittent absent and forward flow, we call it as type 3. So these are different because type 3 fetuses, 15% die unexpectedly, and 20% of larger fetuses suffer from parenchymal plane lesions. Type 2 can have sudden IUFD. So we need to judiciously find out when to intervene to save the other baby. Okay, so this is TTTS. We've already seen that. And let's move now to the other one. Right. Now, this one more importance of doing MCA Doppler in twins, in monochronic twins. So here you can see one fetus, an MCA Doppler, another fetus MCA Doppler. What is shown is we do the peak systolic velocity, and this multiples of median is 0.6. Whereas here, this baby is having a multiples of median of 1.57. So 1.5 mom we know is anemic range. So this baby 0.6 mom is less than 1 mom is polycythemia. So it is twin anemia polycythemia sequence. We can diagnose this only with MCA Doppler. And then we can grade it. If it goes more than 1.7 mom, then you know the hemoglobin difference between the two babies is more than 11 grams, and it becomes very quite serious. So we need to manage that. And then lastly, of course, co-twin demise, right? When you talk about co-twin demise, uh, it can happen post-laser or it can have spontaneously in an MCDA twin. Whenever you see a co-twin demise, immediately we must do MCA Doppler of the other twin. And the MCA Doppler, the surviving twin, when you do very quickly, if you see very high peak systolic velocity and you see an anemic range of peak systolic velocity, then what is happening is this baby had the normal baby has exsanguinated, the live baby has exsanguinated into the dead baby. And that is dangerous because a few weeks later, you'll find brain parenchymal abnormalities in the surviving twin. But if you see no MCA changes immediately post laser, post IUD, then those babies do definitely better. So doing it, if you see immediate 48 to 72 hours, what we need to do is you need to do weekly monitoring and do an MRI at 32 weeks to look at whether any lesions are there. So I leave you with some messages. Color Doppler is useful in several situations other than fetal growth restriction. MCA-PSV is key to the diagnosis of anemia, and color mapping useful in specific anomalies and mandatory in the diagnosis of cardiac anomalies. Serial Dopplers in MCDA helps to identify complications and plan effective management. I will stop here. We still have about 4 minutes. I'll be happy to answer any questions.
So the questions are too many, from
Yeah, I
very
know.
basics to.
We can take a few questions, not a problem.
Vaidehi,
Yes.
can you?
Yeah, I've just posted that they can now start posting the questions. Till then, I'll take the one. Yeah, sir, ICOG says that no need to do MCA-PI less than 32 weeks. Are we following that, or there is a role of MCA-PI in any week of gestation?
So the thing is, when you do Doppler for growth restriction, your trigger for doing Doppler is when the AC falls below the 10th centile, right? Now, as Chinmayee said, there are two types. One is called early onset growth restriction before 32 weeks and late onset growth restriction. Below 32 weeks, why they are saying MCA-PA is not required is because the cerebral redistribution will be seen in an early onset growth restriction as part of a routine physiology. It has to happen. There's no other go. I am not going to make any decisions based on cerebroplacental ratio in early onset growth restriction. And that's why it doesn't have value, right? But for me, when I see a baby AC less than 10 centile, I will definitely do umbilical artery Doppler and middle cerebral artery Doppler. And if I see MCA redistribution, then I know that there is definitely an FGR in place there. There is a placental dysfunction in place. So it helps me to the diagnosis. I may not make any decision to deliver the baby based on the MCA-PI, but it helps me to understand the physiology.
So there was this question which was asked when Dr. Chinmayee was giving her talk. Is it possible to have MCA showing redistribution with normal umbilical flow?
It can happen in late onset growth restriction. In late onset growth restriction, this can happen because in late onset growth restriction, there is a oxygen diffusion defect, where the baby is the brain responds to lack of oxygen very quickly, and at that time the tertiary villus arteries are still open. Their resistance does not change, and that's why you do the cerebroplacental ratio.
So two very basic questions. Sorry to ask you, take you to very, very basic questions.
No problem.
As an obstetrician, we are not very conversant with color Doppler, but enough that we can understand the middle cerebral artery. But technically, I find that when the patient is in labor, which is the time I am quite comfortable to see, like sometimes patients are booked and they come late in labor or whatever. I find it technically difficult to, see the MCA. So that is one question. Another question I want to ask is, these are hemodynamic changes. Do they happen and then revert? Like sometimes you may have a change and then does it come back to normal? Like, what is your experience?
Okay.
Sorry for such a basic
No,
question.
no, no. These are important questions too, because when you talk about doing MCA Doppler in labor, I don't find there's value for doing that at all. Okay, because it will be during last stage of pregnancy, before delivery, there will be significant changes in the MCA flow. So I would not recommend doing, because at that time we only want to know the CTG is normal or abnormal, because we are looking at acute hypoxia, and we are looking at the presence of umbilical artery in case for wanted to know the heart rate and nothing. That's all. Otherwise, I wouldn't do that. Now, secondly, regarding the reversal of changes. So if you look at in early part of pregnancy, now many times we have noticed as we do the scan, suddenly the baby will show bradycardia, right? And then a few minutes later, it'll come back again. So this is it could be because of excess pressure on the heart, or simply the heart just takes a rest a little bit time and do that, which is fine. Now, when can this change happen? Is when there is spasm of the vessels. So sometimes that's why we say when you see an absent diastolic flow in the umbilical artery, just by doing one Doppler at that time, don't come to a conclude. Let's say this baby is growing 26 weeks, the AC estimated fetal weight is in the 11th or 12th centile, and then you suddenly see an umbilical artery showing absent flow, and then immediately all hell breaks loose. It's going to happen. So what you need to do is make her wait for a few minutes, go and have a cup of coffee and come back, and you do the Doppler, it will come back to normal again. So this is often that happens, which you should do. So persistently, you should reproduce the abnormal Doppler to
Yeah.
do that.
So that is very important.
Yeah.
And sir, I'm really enlightened because you took us through so many complications in anomalies, like
Yes.
you mentioned about varix, and somebody in our group, I don't remember which, had put in, and
Yes.
because I had no knowledge, so I was
Yes.
like fumbling. But now I came to know that all these abnormalities are there, and
Yes.
if a sonologist does pick them up, then
Yes.
as an obstetrician we should take, like,
Yes. You take
kind of,
cognizance of that.
yeah.
Yes. Yes.
Thank you, sir.
Yes.
So there's one more question. Why is there an improvement of Doppler after steroids? What happens?
There
Ah.
isn't any improvement. In fact, baby becomes a little bit sluggish.
No, I think that has been documented that with steroids, some uh, Doppler changes can happen. Well, to know the exact mechanism is quite difficult, or I have not understood it as yet why it happens. Also, you don't see too many studies based on this, which is there. And is it going to actually change your clinical management? The answer is no, because just because you have given the steroid, thinking that she is going to deliver, and just because the Doppler has changed, you can say, okay, now I'll go, I won't deliver. Wait for 2 more weeks that I will not deliver because it has changed. So the exact mechanism I'm unable to explain at this point of time.
Okay, sir. So we'll just take two more questions. If CPR ratio is at third centile, in during 36 weeks? Should we deliver at this gestation or wait?
Okay, so this is a constant thing, isn't it? And there has been several papers which how do you report CPR? Okay, CPR, you have two ways of reporting. One is CPR less than one and greater than one, and the other one is using CPR percentiles. Okay, the more the more you embark on using percentiles, the more confusion you are likely to get. Okay, so a simple thing of greater than one and less than one will give you a much easier, and this has been shown to be as effective as doing them, because the cutoff of am I going to use the fifth centile or am I going to use the third centile, the significant thing is normally we expect the cerebral resistance to be higher than the placental resistance, because placental resistance keeps reducing over a period of time. So the denominator is lower, the numerator is higher, so it will be more than one. In this one, what happened then? The cerebral resistance starts going down and the umbilical resistance started going up. So when you have that reversal, it when it goes more than one, then you get into a problem. When it goes less than one, then you get into a problem. When more than one is what we expect.
Right. So
Yeah.
his upper limit 95th centile of uterine artery mean PI taken 2.35 or 2.5? I didn't get that question.
Okay. I think it changes with gestational age. In the first trimester, it is different, and in the second trimester, we take it as 2.5.
Okay. And so just one more question, though not so much related to Doppler. Which are the third trimester anomalies one must know about?
Oh, third trimester anomalies. That is one big lecture by itself. But in simple terms, I'll let you know. These are called evolving anomalies. Okay. One, cardiac anomalies can evolve. Okay. Second, ventriculomegaly in the brain can evolve. Third,
GI.
renal obstructions can change drastically within a short few weeks. And the skeletal abnormalities can evolve, can have late onset, the small femur or other things which can happen later. These are some of the anomalies which you can think of. And as I told you, vein of Gallon aneurysm, and also any AV malformation which was quiet in early pregnancy suddenly can blow up in the third trimester.
Right. Thank you. Thank you so much, sir. I think, ma'am, should we now conclude today's session?
Yeah, I think it was brilliant. And I think I just have to confess that with you, Dr. Suresh, and with Chinmayee, we
Yeah.
become more and more greedy. I'm just thinking which month we will call you again.
Yes.
And this time, we've already
Anytime.
spoken to Chinmayee and to you, sir. Please
Yes,
coordinate between the two of you. We
sure.
just want the crystallized knowledge.
Yes,
So
yes.
what every obstetrician should know about,
Screening.
screening, and we should not
Correct,
over screen or under screen,
correct, correct,
and
correct.
how we can put this knowledge, and whatever you think, like you people have got, I don't know, so much of
Yes,
mine of information. So whatever you think will be important for obstetrician, please
sure,
share that, and we'll come again, I think in December, where they,
Yes, ma'am. Post
yeah.
Diwali.
So for all
sure,
the 200 plus doctors who were there, who were listening avidly, a very,
sure.
very warm thank you. Thank you to Dr. Suresh and Dr. Chinmayee and all of
Yes,
you. And of
yes,
course, you, Vaidehi, who are always there. So
yes.
thank you,
Thank
Thank
sir.
you,
you.
sir. Thank you, Dr. Chinmay, for making color Doppler less intimidating for us. Thank you so much.
Bye.
And sir, today we were forced to make another group because we already have
Oh.
1024 in two
Oh.
groups. So today's was a landmark session
Yeah, yeah.
that we were had to make a link for our
Yes.
third group. So let's hope we all
Okay.
continue to learn nicely, so that we
Right.
don't just ask tests, we
Sure.
ask the tests and know how to apply the knowledge. Thank
Okay.
you, sir. Good
Okay.
night.
Thanks, sir.
Thank you,
I have
Bye.
everybody.
posted the
Bye.
link of the group 3 that we
Also,
just made.
also, I'd
Yes.
like to mention that the next World Congress is going to happen in Dubai,
So,
Okay.
and it's going to be next September 6th to 9th.
Okay.
And I think we would like maximum representation from India, because I've been telling them that we should have a World Congress in India.
Yeah.
We've been pushing for that, but they are little skeptical. Apparently, they wrote to the Foxy did not respond to some communication which happened, and they, we felt very ashamed that all countries are getting World Congress and we are not getting it.
So
And we
never
have,
mind, we will get someday or the other, doesn't
yeah,
matter.
yeah.
Where
No, no,
our doctors are being,
it must happen.
educated and empowered.
It must happen during my time now. That's
Yeah, we will
important.
try. We will try for that, Vaidehi. So
Yeah,
please share us the link and
Link.
everything. We will
Link.
continue
yeah,
to put it,
yeah,
and we'll encourage people to
yeah,
join the
yes,
session for active learning,
yes,
not
yeah.
for just selfies.
Okay, thank
Okay,
you.
good night. Thank
Bye.
you,
Good night.
sir.
Thank you, everyone.
Thank you.
Thank
Good night. Good night,
you.
everybody.
Not a part of our WhatsApp groups. I posted the WhatsApp link, group link in the chat box. Please check it and you can join our WhatsApp group. Thank you so much, everybody. Good night.